Good evening, everyone. Here Imran Abbas. Again, we are live. I am live from Dubai and Professor V.J. Lee from Taiwan. It's great honor to interview such a prestigious figure. As my viewers, you know, we have completed our 4 interview series. And now this is our 5th interview series. And every interview series was for 6 months. And in this interview series, we will try our best to convey the message of experts. So definitely I interview always someone who is expert in that specific field. And nowadays, as you know, so this revisional bariatric surgery is going to more and more common. And we must know about revisional bariatric surgery. And in my opinion, when this interview series and these interviews are at least 5 years ahead to text. So just now we have access to someone who is well-known bariatric surgeon, who is pioneer of bariatric surgery, no doubt. Professor V.J. Lee. Sir, please, over to you, sir.
Hi, Abbas. Nice to meet you. Good evening, everyone.
Sir, please. So we will continue our, as you know, so we have completed our 4 interview series. And I remember your interview in MGB OAGB series. That was amazing, no doubt. And at that time also, that was one of the best interview. And definitely today also our expectation is same because this revisional bariatric surgery is also now going to popular and more common, especially after a sleeve gastrectomy, after weight regain, after GERD, after a sleeve gastrectomy, and many others also, Roux-en-Y and as well as MGB. So, sir, this is the time to know more about revisional surgery. So, it is your time, and so please, sir, you are. We all know you, but again, we are interested to hear from your side, especially about your experience of revisional bariatric surgery.
Okay, that was really an honor to come to GLS again. I think Professor Imran Ababa has played a lot of focused and work on this field. So I will try to respond to his questions by showing some slides. So the first is to brief introducing experience of mine in this field. I started bariatric surgery from 1987 to now. I think it's almost 25 years, and my personal series is around 7,000. And you can see the most commonly performed procedure, as just mentioned, is OAGB for me. But revision surgery is also a significant portion. It's around 16% in my practice, and it's start and lower at the beginning, but more and more and higher. In this week, I performed 7 surgery, and 3 of them are revision surgery. So now it's a more and more common. And in overall, the data, if we look at the revision surgery, you can see many have the second revision, even third remission. So it's quite common for bariatric surgeon to face reoperation if the patient, because obesity is a chronic illness as lifelong suffering of the patient. So it must have a chance to do revision surgery for them. Okay. So the second question raised by Ababa is, how can we define revision, conversion, and correction? I think many of you have already know these words, but I think overall, if a bariatric surgeon receives an operation related to the previous bariatric surgery, we can call the patient had reoperation. And usually it's associated operation because like a gallstone, ventral hernia, ileus, etc. And if we touch the primary bariatric procedure, we call it revision. And most of them can divide into two parts. One is conversion. Conversion means we change anatomy. So we usually define conversion to what procedure. You can convert sleeve to a bypass or bend to a sleeve or conversion even to normal anatomy. And another word is correction. Correction means we did not change the anatomy, but we just a correction the procedure. Mostly common see maybe re-sleeve or the prolapse of gastric bending. We need to reduction of the procedure, or we change the bypass limb in OAGB. I think this can be classified as a correction surgery. But overall, I think all this can be called revision. So like usually I think many have seen we have done many gastric band before, and now it's less. But sometimes the most commonly complication of this is prolapse of the band. So these two video all shows the prolapse of the stomach into proximal cause some obstruction symptom of the patient. So in this kind of situation, we need to correction the procedure, and usually we can lysis adhesion and pull back the prolapse part and keep the band inside. Because if the patient don't want to take it out and the weight loss is okay, we usually can just correction the procedure. This is one example of the correction. Now we reduction and we refix, but we did not change the anatomy of the procedure. Another situation, yes, is a failure of band. Like this patient had weight loss, regain unsatisfied, and we can see a achalasia change of the esophagus. So this time, usually we need to conversion the procedure, conversion the band to either to sleeve or bypass. And the third question is, how do you define failure after bariatric surgery? I think this is a quite interesting and controversial question. And there's no real answer for this simple question, because the failure needed to define from the patient's view. He don't satisfy with the procedure either due to the weight or due to the quality of life. And second is from surgeon's view, because we need to identify whether the procedure has some anatomical defect or whether the procedure can have a comorbidity remission or recurrence. So this is all depends on from which point. But usually if we have agreement both of the patient and the surgeon, then we can proceed to a revision surgery. So the failure should be defined, I think, by both the patient and the surgeon. Of course, there is some definition like weight regain over 20%, something like that. But I don't think it's so simple can be stratified defined. So in different procedure, yes, but we can see in an old procedure like VBG or gastric bending, the revision rate is quite high, almost to 20% in the procedure. Then the common procedure now we are doing sleeve RIGB or OAGB, it's similar, around 5% of the patient need a revision surgery. So this is a overview of the current procedure. We met around 5% of patients require a revision surgery. And most of the reason, if you see the bottom two line, you can see there's for sleeve, most of is due to the reflux, and one third of patients due to weight regain. But I think the situation had changed as I note, because at the beginning, there's some technical problem of the sleep. So we met more reflux in revision. But nowadays, I think the technique is improved. We are now notice there are less patients who have a reflux require revision. But at the long term, more and more patients, the weight regain after sleep. For example, in this week, the 3 revision for me is all sleep with conversion to the other procedure. They are all weight regain. They don't have a reflux problem. And for the RIGB and OAGB, the situation is also different because for OAGB, the malnutrition is a problem. And for RIGB, I think most of is due to other complication of the RIGB. So the question 4 is, what is a technical consideration for revision as surgery? I think on technical point, when we have a revision surgery, we always need to back to examine what we know about the mechanism of bariatric surgery. For a good bariatric surgery, you need to have a good weight loss, resolution of comorbidity. That really depends on how much restriction we can apply to the patient. That's mostly is restriction and consists 70% of the mechanism. And malabsorption consists 30%. And play a role in metabolic component. So we need to think about this and examine the procedure we want to revision and think about what we can do. So it's a key point. I think, of course, we need to check the lifestyle of the patient and need to improve the lifestyle of the patient. Then the most important thing is we need to look at anatomic defect. Usually the pouch is dilated. We need to trim the pouch, or the anastomosis is too wide. We need to remake a small anastomosis, or we did not bypass enough. So we need to check the bypass ratio. Should I continue, Ababa, or
Sir,
you want to?
yeah, sir,
Yes.
I want to discuss some questions. So you
Okay.
can also this I think stop sharing. Then we have some question,
Yes.
and then we will continue. Sir, regarding yours, first of all, really amazing. It's definite as my expectation. This will be one of the best session, no doubt, because completely organized session, and also you are covering all the related question. My question, so you have mentioned in your slide, so revision of Roux-en-Y and OAGB, and you mentioned the reason is GERD, internal hernia, or other like marginal ulcers. In that, so you have mentioned 61% overall the revisional surgery, not all surgery. So if we have figure 10, so in 10, so 61% in Roux-en-Y gastric bypass, the reason was GERD, reason was internal hernia, and other reasons. But in OAGB, it was 18%. So if we compare this point, only this point, that was. So what is your opinion? The main cause, because if we can compare GERD after any type of surgery, always we think, okay, Roux-en-Y gastric bypass is one of the rescue surgery if someone is suffering with GERD after sleeve gastrectomy. So this is just my question. So definite we cannot, this is our thinking. So then there will be less GERD after Roux-en-Y gastric bypass. Have you faced GERD after a Roux-en-Y gastric bypass? And if you faced, how you resolve that one?
I must first say, because this is my personal series, and we do the bariatric surgery in quite a long time, so we had a learning curve in every procedure. So I think we face a lot of revision because we don't know something. Then we improve the technique. So in nowadays, I don't think the revision will be so high still, because in my early time, we did not close the mesentery for Roux-en-Y, or did not fix the loop for OAGB, something many things, and did not count the bowel length. So we do have this kind of revision. But nowadays, I think the surgery procedure is quite mature. So the revision probably will not be so high. This is the first point I want to mention. And also I want to stress we need to do the most update technique in each procedure to avoid this kind of revision. Yes. And for reflux, I think all the procedure had a chance to have a reflux because in bariatric surgery, we create a very restrictive part of the stomach, either in Roux-en-Y or OAGB or sleeve. So this kind of small part, high pressure, tend to reflux. So I think it's quite common, yes. And for Roux-en-Y revision, good. I had a case. For me, it's the most commonly reflux in Roux-en-Y probably is related to one is candy cane syndrome. Yes, you have a dilated part of the gastric pouch, then the food will go stay here, then the patient tend to reflux. In otherwise, uh, theoretically, reflux should not be happen in Roux-en-Y gastric bypass because Roux-en-Y is a treatment for reflux disease. But it do happen. It have some problem in the Roux-en-Y technique, then the patient still can have a reflux. And usually we need to fix it. Yes.
Sir, another question regarding, so this is also, I want to know your opinion regarding truncal vagotomy, that nowadays also some of our colleagues, they are talking about this. So what is your opinion?
I don't see any side effect after truncal vagotomy because in the early times we do many truncal vagotomy for recurrent marginal ulcer in the area of peptic ulcer disease. It's a quite standard treatment. In bariatric, I also do around 30 to 50 number of truncal vagotomy. Most of is due to a marginal ulcer. We want to reduce the acid, and sometimes in some intrathoracic migration, when we want to reduce the migration part, sometimes we need to do truncal vagotomy to release the tension, so we can bring the stomach part into the abdomen. And I don't see any side effect from doing this kind of truncal vagotomy. So if you need, for my personal opinion, you can do it. Yes, no problem.
Sir, another question regarding intractable GERD in Roux-en-Y gastric bypass, and also you used all types of medicine, but no response. Have you faced such a situation? And if you have faced, how you resolve surgically?
I think I think nowadays, if you have an intractable GERD after Roux-en-Y, you always need to investigate what is the reason of this reflux. Usually you can find a reason. If you can find a reason, then you can fix it. As I mentioned, usually you can have a candy cane of the dilated stomach bright pouch, or you can have a big gastric pouch. It will also create. Or sometimes we can see intrathoracic migration of the gastric pouch. If the gastric pouch migrate into the thoracic, either OAGB or RUIGB, they all cause a reflux intractable GERD in the patient. This kind you usually need to reduce back the gastric pouch, close hiatus, and make the anastomosis wide enough. Then I don't think there's any reason why still have the reflux. Yes.
Sir, what about marginal ulcer in Roux-en-Y gastric bypass and also intractable marginal ulcer? Sometime, so we also face such a situation in smokers. So now the patient, maybe you didn't do
Yes.
this, but maybe so another your colleague so refer and they did Roux-en-Y gastric bypass in a heavy smoker and patient is still smoking. And you know,
Yes.
so he will not quit the smoking. So what you will do in such a case?
Yes. I think in your country and as well as in Asia, they still have 30% to 50% male smoke. So the incidence is quite high. So in this of a case, I always happy to perform truncobulgotomy. And also we need to trim the gastric pouch small enough because sometimes it's related to hyperacidity. So if you can trim the gastric pouch and do the truncobulgotomy, in my series, I don't see any recurrence of the ulcer after truncobulgotomy. Yes.
Sir, then are you recommend in a patient, so because as you have mentioned about 30% of our population, male population are
Yes.
smoker, and as you know better than me, so smoker, they never quit, they will smoke, and we know.
Yes.
So because why I am asking this question, you are one of the person, so we always see your side, especially guidelines. So can we recommend this in all smokers? We must go for truncal vagotomy.
I don't have I think we don't have the evidence to. One of my colleague is now running a randomized trial but I think it is under randomized trial, so we can wait to see the result. If the result is positive, then we have the evidence to provide the patient. At this moment, I don't think it's a good suggestion to do prophylaxis truncobulgotomy. Yes, until we have evidence. Yes.
Okay, sir, regarding OAGB, you have mentioned also 18% of this revisional surgery is related to this group with the GERD after surgery, reflux after surgery, or internal hernia. Have you faced any time internal hernia after OAGB that you did surgery for the case? Because I think you never closed that Peterson defect.
Yes. And up to now, I still don't met anyone come to me with internal herniation due to OAGB. Yes, yes. And I do have a patient have a reflux after OAGB, especially acid reflux. So now I realize some patient is really due to introthoracic migration of OAGB because OAGB had a similar narrow gastric tube as sleeve. So if you notice, some of the patient will have introthoracic migration. So if you have a patient reflux after OAGB, and you see the introthoracic migration of that part, maybe you can do revision to correct that introthoracic migration. Not necessary to change to Roux-en-Y. Yes, I had several cases to have this kind of situation. Yes.
And just you reduce and did chloroplasty, that is sufficient?
Yes, yes. But you make sure the outflow track is very smooth by upper GI stream or by endoscope. Yes. Then we just correct the hiatus hernia, pull down the gastric pouch. You can solve the problem. Yes.
Sir, you have also mentioned in your presentation, nowadays we face less GERD after a sleeve gastrectomy. Is it
Yes.
due to patient selection or technique? Why you are facing
I
less?
think the technique. I think the technique. Yes. Because for ourselves, we also create some severe GERD in our initial, yes, 5 years, I think. But nowadays, if we do sleeve, I think the technique is quite mature. So I don't see many reflux from sleeve now. Yes,
Thank you. Sir, please continue your presentation.
sure.
We were at fifth question.
Good.
Now sixth one, I think.
Yes, key point. Yes, indication we just checked. Yes. So indication, I think everyone should know is a complication or weight regain. So if a patient have a clear complication, if significant weight regain with recurrence of comorbidity, or patient have a long-term complication like reflux, marginal ulcer, or a malnutrition. And the second is we can find a clear anatomic defect. We can know what we can do to fix. And the patient have acceptable risk This is the same as primary bariatric surgery as other major operation. And the last one is a mutual agreement and a commitment. We know we can correct anything, and from evidence, we can estimate the outcome, and the patient accept this outcome. Don't have some imagination of the outcome. So this is a mutual agreement. Then this is indication for revision bariatric surgery. So how do we evaluate? I think most important is the history. And do the patient have enough weight loss at the beginning, then regain, or he failed to lose at the beginning? And what happened in the history? Sometimes the patient have childbirth or have some stress situation, they change their lifestyle. So in this situation, we need to mention the patient need to make some motivation of lifestyle change. And then we need to understand what is the expectation of the patient for weight regain, and what is anatomic defect, what we can fix. Then as the last slide, if a mutual agreement, then we can do. So do we have a protocol to decide? Yes, I don't think this is not a single simple answer to this, because we need to personalize procedure, and also should be very precision procedure. And usually this is art based on scientific evidence. So I also change my practice. For example, for a sleeve with weight regain and no significant GERD, in 2 years ago, I think the first choice for me is OAGB. But now the first choice for me is SASI. And I think this is changed because when we understand we have more evidence and more better choice, we will change our procedure. Yes. So the ninth question is weight regain after sleeve gastrectomy. Yes. So for my personal, we should try lifestyle and medication first to see the response and to see the cooperation of patient. Then if fail of this, and we find usually the recurrence weight regain after sleep is always due to the sleep dilatation. And in this situation, the first choice now for me is re-sleep, but I will add a bipartition bypass. Now it's called SASI. Yes.
Sir, we have some question.
Yes.
Okay, you can, so after this slide.
Okay, I will finish this question. So in my all personal series of the sleep, the revision rate now have around 5%. So in this 74, you can see, because as I explained, in a long period, at the beginning is a more reflux disease. So in reflux disease, the choice may be LUIGB or the gastric tube is okay, I will try OAGB. And in one time, I tried many hiatoplasty with gastroplasty. But then I find this procedure is not enough. If you don't change the pressure, the reflux cannot be resolved. So I quit this hiatal repair with gastroplasty. And in some time, I also tried DJB, but I don't think it is a good choice because the operation is too complicated. So now my preferred is OAGB or SASI. So this is the report of my 13 years experience in sleep revision. So the most important thing is we must reduce the intrathoracic migration part of the sleep. This usually is the main reason for patients have persistent reflux. And as I mentioned, if we don't change the bypass, we just close hiatus and make a gastroplasty for, we can have a partial remission of the symptom, but usually the patient cannot quit the operation. You can see at the 6 months, the patient has around 6 to 70% response, but the symptom will recur in a longer follow-up, 1 or 2 years. So this is not a procedure for me now. And if you choose not a good procedure for revision sleeve, sometimes you may face a third revision surgery for sleeve. For example, in those 34 patients, we just do hiatoplasty with gastroplasty. Many still suffering from reflux, so we need to change to a reflux. Or some patients then later develop the marginal ulcer, we need to do trochanophagotomy. Or many other situations. So this is, I think, and for revision surgery, of course, for the weight regain, in our study, the OAGB had a better weight loss than RIGB. So if you want to do RIGB for sleeve due to the GERD issue, then my suggestion is you need to extend the BPD to make it as a OAGB, yes. Okay, I will stop. Or the last case, I will share the case I do 3 months ago. This patient is a 56 years old. He had a sleeve 2 years ago. At the beginning, the surgeon wanted to do bypass, but the patient had a peritonitis before. So small bowel is adhesion very severe. So the surgeon quick only do sleeve. Then you can see at the beginning, the patient can lose weight from 120 down to 85 and resolution of diabetes, hypertension, sleep apnea. But then you can see the weight recur in 2 years. So when the patient come to me, he had exactly the same body weight as before. So I look at this is the upper GI to showing the sleeve had a quite big sleeve. So we can still see a part of the stomach there. So because he had a weight regain after sleep, and sleeve itself looks not really a back sleeve. And the patient had oral comorbidity recurrence. Patient no GERD. So the diagnosis is dilated sleeve. So the planning for the patient is to re-sleeve, then make an anastomosis entrance, we call by partition SASI procedure. And this is a port we place. Then we trim the sleeve tube. This is a trim part of the gastric pouch. Then we make anastomosis at the entrance and bypass 60% of the small bowel. And we use robot to anastomosis because in this angle, you use your hand is very difficult. It's make a ergo very bad situation for a surgeon. So I prefer to use a robot to do anastomosis. This is a finish. This is the upper GI to showing a bipartition. And now 3 months after the surgery, the patient regained his way back. And you can see he also remission all his comorbidity now, just 3 months by adding a SASI procedure. And there's also some report, SASI can be considered redo for fail the sleeve. Also, some extreme situation is now some surgeon like to do sleeve plus JJB. I don't think it is a recognized procedure because no enough data to show a long term. So I met some patient with weight regain after this procedure. So the revision is the same. You still can do a SASI on a distal part and just neglect the JJB, and you can still have a good result. This is the patient we do. Okay. Okay, I will stop here.
Sir, thank you. Sir, I have some question. So you can stop sharing. Yeah. Really,
Yes.
again, it was completely and everything is clear. But for myself and for my viewers, I have some question. One of question is surgical intervention. When you do surgical intervention after insufficient weight loss, so someone did sleeve gastrectomy, there is insufficient weight loss that we all know the definition of insufficient weight loss. And you also started some medication, lifestyle change, use of MDT, nutritionist, everything, but still insufficient weight loss. When you will decide, which time you will decide to go for another surgery in this patient?
I think the most important for me is the patient have a good intention. He make a cooperation with you, but still cannot lose enough weight. The second is you find good anatomic defect. That means we find something we can fix. Because we are surgeon, we can only fix things. We cannot really predict outcome. The outcome need to be accomplished by the patient. So you need to be familiar with the patient and know this correction can help the patient. Yes, I think that's a very important things. Yes.
Sir, when
So
you
for me, I always
when you will go after 1 year, after 1.5 year, after 18 months, when you will decide how much time you can wait. So then now you will ask, no, we must go. Yes, there is dilated pouch. You can analysis. Yes, sometime we have standard sleeve gastrectomy, but still insufficient weight loss. So when you will decide to go for next surgery or conversion or add a SASI or something like this, when you will decide?
yes, it's a very good question, but I don't think this has a simple answer. But if my cell patient and I will wait at least 6 months, and usually is the longer the better because you can understand. And in many situations, is patient don't come back to you. Either they are doing surgery outside or doing by you, but they don't come back. And one day they come back, then it's maybe 2 years or 5 years. So in that situation, you don't need wait too long because you only need to investigate anatomy and try medical treatment and communicate with the patient. Maybe 1 or 2 months is enough for you to decide whether to revision or not. Yes.
Sir, regarding weight regain, that is also, we all know, and also on the base of there, so definite, there is already definition of weight regain, especially because now we are talking about sleeve gastrectomy. Again, my same question, when we will go for next surgery or conversion surgery, so when you will decide? So just imagine 3 years now after a sleeve gastrectomy and patient, that definition of weight regain. So, and also there is some comorbidities. Is it also necessary to see reoccurrence or relapse of comorbidities? When, because we need to hear from your side, sir. We're interested.
I think the most thing I like is the patient really have comorbidity recurrence and he start medication again. So we can have a clear common end for both the surgeon as the patient. We can do a procedure and the goal is to reduce weight and resolve the comorbidity. So I think that is more clear, yes. So I like this indication most. But sometimes patients only have weight regain and they don't have a really comorbidity come back because as we know, maybe 50% weight loss is enough for resolution of a comorbidity. But the patient have weight loss at the initial maybe 30-40%. Now they come to only 20% weight loss and comorbidity is not yet come back, but the patient is really unsatisfied. So in this situation, sometimes if I see some clear anatomy I can improve, I will also accept the revision. But now the common goal for me and the patient is to reduce weight back to his original lowest point. Yes, so we need to clearly define what you are doing and what is the aim. And is it possible for you to do it? So I think that this is my philosophy. Yes.
Sir, one of the most common comorbidity in obesity is diabetes. And as we all know, diabetes is not related to weight loss. So diabetes is related to hormonal changes. And so rise of GLP-1 when undigested nutrients go to terminal ileum, and then this GLP-1 and PPI from, so especially GLP-1 from L cell of terminal ileum, and then impact of this GLP-1 on beta cell and hypertrophy of beta cell, and also increase the sensitivity of GLU2 receptors on muscles and many things. So then decrease of incretins that are anti-insulin and many other impact. And also these things we know. This is not related to weight loss, but again, sometime, because in personal also in my experience now I can see still patient, yes, lost weight, everything was okay, honeymoon period left, now 2 year 3 year everything was okay. And patient before surgery was 40 42 43 BMI, now BMI so touch 25 again, now 28 29. But at this stage, that is again thing. So this that comorbidities again relapse, and especially diabetes relapse, and this was the complaint of patient, because patient was thinking about this. So when I will do this surgery, because in our region, especially in Dubai, BMI 38 39, so they ask is healthy, they don't ask so this is obesity. So this is very important that
Yes.
because their dress, everything is so like this relaxed dressing, and always the BMI 40 is also for them is okay, there is no issue, not obesity. They ask so I am healthy. So the concern was not weight at that time. Then we did surgery. At that time, the concern was comorbidity, especially diabetes. Now patient is, according to him, is thin, not is obese, BMI 28, 29. So according to definition, yes, overweight, but diabetes again occur and he started to use medicine. What we do in this case?
Yes. I understand your question. Yes, because obesity itself, they don't think it's a disease. Yes, but once he has diabetes, then he think it's a disease. Yes, yes, we can treat diabetes, but we can treat diabetes, not diabetes.
Yeah.
That means the patient must have some weight, overweight, or mild degree obesity that we can treat, because we are through reducing weight to decrease the insulin resistance, so we can use the insulin in our body. Yes. So if the patient doing sleep, I don't think it's enough for diabetes. Yes, because it omits the gut hormone part. So the patient had recurrent weight with recurrent diabetes. I'm so happy to do a bypass, either OAGB or SASI. I do see good response after this procedure, and patient can have diabetes remission again. Yes. So I think have diabetes is a very good indication. If a patient have remission, then recurrence, that means if you can reduce the weight back to his lowest part, the patient can have the remission again. So it's quite comfortable for us to do this kind of remission. Yes,
Sir,
I
another
agree.
question
Yes.
before going to your presentation. So my question again about weight regain after sleeve gastrectomy. So yes, you have
Mhm.
decided to go for surgical intervention, and you have expertise to do SADI. You can do SADI or DBG, as you know better than me. You can do. It means Professor Lee is a surgeon, not myself. So he is doing. He is. What will be your selection? You can also do OAGB in this case. You can also go for
Yes.
DBJ or for SADI. So what is the difference in these both? So for my viewers, I am asking. In SADI, so this will be enterostomy. It will be duodenal-ileostomy or duodeno-jejunostomy. It means small bowel to small bowel, this anastomosis. But in OAGB, this will be gastrojejunostomy. So now you
Yes.
can select this because this is very important for myself because you have now more than 2 decades experience. Which surgery you will select? This between these, you can also do Sadi. That is also effective. You can also do OAGB. Is any difference? Are you think?
Study I will never do again because you don't see any really good effect from study. What study can do, OAGB or SASI can do. You just bypass longer. Yes. But for study, it's really more difficult to touch the duodenum. And the angle to do anastomosis is also difficult. Yes. And risk is higher than OAGB. So I think OAGB is the most simple and most straightforward with good effect. But for problem is if a sleeve gastrectomy, you do a OAGB, you will meet a dilemma. You will have a small entrance, whether you resect it or not. Yes. And also, sleeve patient can have some bile stone or sludge in the gallbladder. So they have a higher chance for the future to have a common bile duct stone or gallstone. So sometimes you need to have a duodenal pass. So in that situation, for sleeve revision, I will see SASI have a good advantage because you have a duodenal pass, so you don't worry about a future gallstone problem. And you only need to make osmosis over entrance. You don't need to consider whether you need to resect or not. So I see many advantages in SASI in revision sleeve. So I personally think this should be the best choice. But for the primary surgery, I still like OAGB because I don't like to resect sleeve at this time.
Sir,
You know, I mean, yes.
yeah.
For primary bariatric surgery, OAGB is my first choice. For sleeve weight regain, SASI is my first choice now.
Sir, SASI is that you are doing is loop or SASI bipartition.
Loop, loop we call SASI because SASI is a single anastomosis,
Yeah,
sleeve ilioanastomosis.
yeah.
Yes, but they don't use the name bipartition. I don't think it's fair to the original procedure because original this procedure called bipartition.
Yeah. Sir,
You know what I mean?
yeah, I
Yes.
understand. Sir, regarding this weight regain after sleeve gastrectomy, or you are doing SASI, what is your standard common channel? Because you have mentioned always you measure whole bowel length. So that is again 60-40. 60 mean will be BP and 40 will
Yes.
be that common channel.
Yes, because in SADI or SASI, they only measure from distal. So the suggest is from 2 meter now to 2 meter 50 now to 3 meter. But for me, you need to consider the ratio as a standard point for oral bypass. So I still count the oral procedure and I bypass 60 and I leave common channel 40%. So that's around 3 meter to 3.5 meter. Yes, around.
Common channel. Yeah. Sir, please
Yes.
continue your presentation.
Okay.
We were at 10th, I think, slide. And now we will talk about GERD. That is also very important.
Yes. Good. After sleep.
Yeah.
Yes. So for my philosophy is the patient have a good in sleep. I will evaluate whether the gastric tube is okay or not. So if the gastric tube is perfect, as I showing in previous case, I will consider SASI first. But if the gastric tube is not so okay, then the second is if I can maintain a good tube for OAGB, I will do OAGB. But if the tube is really poor, I can only cut a small gastric pouch, then I will do RIGB. So it depends on the gastric tube of the patient. So I think it's a real issue in sleep. Sometimes you will see this kind of torsion of the tube and severe reflux. Usually, the patient have 3 months and the first 3 months, then subside in most of the case. If more than 1 year, then we can need to find a gastric tube. So in this case, you can see the gastric tube has a torsion kinking like that. So the only part we can use probably is a proximal part. So in this situation, I think we will do RIGB for the patient. Yes. And as I mentioned, in doing the RIGB for sleep, we need to consider whether the patient have obese or not. If patient still obese, we will use a longer BP limb to help the weight loss. But if the patient already have good weight loss, only for the good, then we will use a very short BP limb to avoid further body weight loss. So this is our result, looks okay. But I need to mention now is a more and more endoscope treatment for this kind of good. So you can think about this. Like the common way is a TIF to create endoscope, and or use some future device to do it. You can also. And more simply now is many gastroenterologists now use argon beam laser to ablation the mucosa. You can call this is ARMS, mucosa. Yes, or mucosa ablation, or use the band ligation of mucosa to create a barrier. They can all help in the reflux symptom after sleep. So maybe you can try this first. This is the development of this endoscope technique. You can see from the mucosa resection to argon beam laser ablation, or this band ligation of the mucosa flap. And there's a report about improve of this kind of the symptom by the anti-reflux endoscope resection, mucosa resection. You can have a 60% PPI off. So not a really bad outcome. So we can try endoscope now. Yes. And even new techniques still coming out. I think is innovated by Japanese surgeon. They call anti-reflux mucosectomy and close the defect will help the recover of this kind of procedure. So, and this is a band ligation. Use the band to create a barrier over EC junction. They also can treat. Okay. Then the next question will be, or we need to discuss this question, reflux.
Sorry, yes, if it's possible, yes, just one or two questions. I will not take more time because as you have mentioned, this endoscopic intervention and different techniques you have highlighted, and especially you mentioned our Japanese colleague, because as I know, due to I can ask so most common gastric carcinoma in Japanese, and due to this mostly we prefer to go sleeve gastrectomy in Japanese population. And maybe
Yes.
they have started, and they also promote this endoscopic intervention and also ablation of mucosal ablation or different techniques because they don't have another option. They also maintain that sleeve and also prevention from GERD or reflux. But in our area, when we are talking, so this is just my question, because we have another option also. Okay, we can go for Roux-en-Y gastric bypass, and there is no need to go for such. Maybe in our region they don't have such a sufficient equipment because also they don't have expertise to do such a meticulous surgery because in delicate surgery. Just my question. So in our region, especially Middle East, then there is no this gastric carcinoma is not such a issue. So we can go for Roux-en-Y gastric bypass in such a situation.
Yes, of course. This depends on the patient's expectation and the availability of your gastroenterologist friends. Yes. So I think Roux-en-Y gastric bypass definitely is still a recommended procedure for reflux after sleep. So if you do it, I think it is quite okay. Yes, but most of the patients, they just don't want operation. So in this situation, I think we can try endoscope ablation. And I think by the improvement, some days it will play a big role in endoscope treatment. Yes, especially.
I agree with
Just
you.
like the medication. Now we have a more and more weight loss, good result medication. So they will take part of the treatment burden in this kind of situation. Yes.
Sure. Sir, what is your opinion about links? So, have you any experience?
Links, I think is a bullshit. Yes. At the beginning, it's so imagine, but I don't think because you just don't see any randomized trial or any. Yes, but on promotion, I think it's quite expensive. It's a good business. Yes,
Yeah.
and make no harm, but I don't believe it. Yes.
Sure, sure. Sir, please continue your presentation, sir.
Okay.
Weight regain after Roux-en-Y gastric bypass.
Yes, when we get after Roux-en-Y, it's always a interesting thing. Yes, Roux-en-Y weight regain. It's quite common after Roux-en-Y gastric bypass. Yes, we always see the recurrence rate in Roux-en-Y is always higher than OAGP because we can see the gastric pouch dilate, anastomosis wide, and also the small bowel become very wide instead of like just in take the function of stomach. So this is all the reason why weight regain after RIGP. So my favorite thing is now I think the recommended procedure is to trim the gastric pouch or to suture anastomosis. In this technique, you can see anastomosis is wide. Yes. So there's now a lot of method to treat. Like I mentioned, this is argon beam laser. Just by argon beam laser, you burn a stoma, you can shrink the stoma, or you can use this endosuture design to close the anastomosis. I guess why we use endoscope because the revision of a Roux-en-Y gastric bypass to other procedure is always very risky and quite difficult. Yes, so we now more prefer to use some endoscope treatments or use the medication in combine. So by this kind of technique, you can easily shrink the anastomosis to very small. This is the Apollo suture design system. Just suture who bite, then close. You can close osmosis to small. But if you don't have the endosuture device, pure argon beam laser is enough to shrink the anastomosis small. Okay. So the next is intracranial basal ulcer. So should we discuss about where we get after Roux-en-Y?
Sir, okay. We will finish the presentation then at the end.
Okay. Okay. So marginal ulcer, I think, is quite common in 5% of the patient, and most is due to smoker. Smoker has 10 times risk than non-smoker. Okay. And in severe intractable marginal ulcer, is patient need a PPI and had pain, and also may have this kind of a stricture developed like that. So intractable also one of the marginal ulcer. So the common treatment, I think, is to resect the pouch and do thromboplasty for me. Effect is very good. Intractable GERD after Roux-en-Y, although not very common, but for me, is still for revision Roux-en-Y in my series around 5%. You can see in Roux-en-Y, the most important thing is other reason because we had some complication in our early period, internal herniation or mesentery defect or ileus or exactly. And weight regain also about 1/4%. And some patients still have a malnutrition. And for intractable GERD, it's not so many. So in here, I share one interesting case is he had a Roux-en-Y, and you can see the patient had an intractable GERD. He needed PPI every day. And we can see there's a pouch over here. The dye coming to here, stacked here, and going down. So I think this is, then we do a revision surgery. Then it turned out to be a candy can syndrome. So we need to resect this candy can and correct the anatomy, then close the hiatus. And also a patient have some weight regain problem. So we also trim the anastomosis. We did not redo the anastomosis. We just resect the candy can. And 1 month after this operation, the patient had very good result. So for intractable GERD after Roux-en-Y cardiac bypass, we need to find some reason to correct. And GERD after OAGB is also a similar situation. In OAGB, as I mentioned, most of the revision is due to malnutrition, and weight regain also in sometimes. So for a typical examination, this is to say the revision. So revision for malnutrition, one option is revision back to sleep, and or revision to RY, or change the bypass, still maintain OAGB. This is all the option we can do. So this patient is a intractable GERD after OAGB. So you can see 7 years ago, the patient first operation, we do a nice OAGB. The tube is narrowing down. But 2 years later, the patient come back with intractable GERD and mixed with accident bile. So you can see the pouch is dilated. There's some anastomosis here, some narrowing of the tube. That is one of the questions. And the second is the patient had a hiatal hernia introthoracic migration of that. This is endoscope finding of the patient. And we can see there's a migration of the proximal gastric tube. All this can result in intractable GERD after OAGB. Yes. So I think the solution is quite simple to convert it to a Roux-en-Y gastric bypass, but we must pull down the oral gastric component into abdomen, close the hiatus. In this situation, sometimes we need to resect the truncal vagotomy, so we can pull oral gastric tubes back into abdomen. But don't worry, if you're doing this, still you have a no long-term complication of that, and the result is quite good for this patient. And weight loss, micronutrition deficiency. Yes, so this is a common situation in our practice because in OAGB, there's always have a higher incidence. This is to showing anemia. It will be higher in OAGB compared to other procedure. And also vitamin D and calcium deficiency may also be higher in OAGB. I think this is a price of the efficacy of OAGB, but we can fix it by good supplement or something. If too severe, we can convert to sleeve gastrectomy. Yes. And the last question, I think, is who is eligible for revision bariatric surgery? Should this procedure be done in a medical center? So who is not eligible for revision? As I mentioned, is if this patient has no intention, no good intention, not cooperation, this is eligible. And we find no clear anatomy defect. The sleeve is very beautiful or something, or the bypass is no problem. It's due to a patient and unrealized imagination or something. And also, if you are not very experienced in revision or this kind of procedure, it's also not a good situation to do revision. And should this revision must be in a medical center or tertiary hospital? The answer is no. In experienced surgeon, the revision surgery is only simple as the general laparoscope surgery. So in my practice, half of the revision is done in private clinic practice, half is in medical center, but the outcome is exactly the same. So if you are experienced and you can manage the situation, laparoscope surgery can be done in any hospital, I think, if the equipment is enough and you can guarantee the safe and effective. Yes. So this is my answer for all your questions.
Sir, excellent, really, and it was a definite one of the best session. There is no doubt. So my last question, because I am interested to hear more and more from your side, because always your debate is with lot of wisdom. There is no doubt. So my last question about OAGB, because as I remember in your interview series of MGB OAGB, you have mentioned so 5 year 5 year 5 year 5 year the technique, how you standardized your technique of OAGB, and definite your last version you have mentioned how you do, and also how you do that anchoring suture, and also always suture that gastric tube. And I have also started after that interview same technique, and
Yes.
really I am happy, my patients are happy. My question is about GAID after OAGB, because you have mentioned some percentage. So now after standardizing this, your last technique, still have you faced any GAID after OAGB?
Very few, very few. Yes, I must say
Yeah.
very few.
It means, sir, so because as you have mentioned, now we are facing less percentage of GERD after a sleeve gastrectomy, so less percentage of GERD after OAGB, as well as also less percentage of GERD after Roux-en-Y or weight regain, because with the passage of time and also standardizing the technique. So what will be our our message to home, especially for my youngsters? First of all, there is no gold standard bariatric surgery, but as Professor mentioned, till this time we can ask at least three types of surgery. We are near to standardize. If you will follow that standard technique and standard points, then definite after, and also patient selection, that is also another important point, and role of MDT, because this bariatric surgery is not with solo flight, you need, this is the teamwork, and role of MDT, patient selection, and then your technique, then definitely you will face less complication. Sir, your message for our youngsters, please, any message for our youngsters?
Yes. So if you want to do bariatric surgery, you need to learn a standard operation, as Ababa say. Yes. So sleeve, we know the common sense is you need to leave a long shape and the angle must be wide enough and gradually narrowing toward the EC junction. And you leave EC junction about 1 to 2 centimeter. And I think the now result is acceptable. You can have around 30% body weight loss, maybe in the first 6 months, but the weight will gradually regain. So in 5 years, I always tell my patient you can expect 15 to 20% weight loss, but it is enough for you to have a good health result. But if the patient have diabetes or severe like hypertension, metabolic disorder, I recommend you do gastric bypass at the beginning, because in this situation, most of our patients will recur of their comorbidity. If you only do sleep, the patient tend to regain weight and all the comorbidity will come back, especially diabetes. So you had better to choose bypass at the beginning. And for the bypass, I think OAGB is simple and safe procedure, and now the technique is quite standard. You can expect almost a zero complication rate. For rural gateway bypass, I think it's reserved to those with reflux disease, revision surgery. Otherwise, there's no reason to do a primary Roux-en-Y gateway bypass because at long term, they still have a more complication in small bowel. So if we consider long term, we don't need to take this risk. And revision surgery, as I mentioned today, now maybe sleep with weight regain is the most important revision in the future. So I think SASI is a good suggestion to consider in sleep weight regain revision surgery. This is my summary of today's my opinion. Thank you.
Sir, so much thanks, and my viewers, so much thanks till this time you are with me. But especially thanks from Professor, because now in Taiwan is midnight and Professor
Yes.
is with us, and we will continue this interview series of revisional bariatric surgery. And next week, Tuesday, 10 p.m. Dubai time, we will be with another legend of bariatric surgery. Sir, so much thanks. Have a nice time.
Thank you. Bye-bye. Good night.